Welcome, everybody. I'd like to introduce you to Dr. Ellie Albertson. She's a data scientist at Cedars-Sinai Health Systems here in LA, where she develops machine learning pipelines to improve clinical care and patient experience. She holds a PhD in public health from UCLA, where she completed interdisciplinary training in advanced econometrics, okay, and statistics. She has over a decade of experience in data and analytics in healthcare and social services, and is passionate about addressing bias and fairness in data science. So take it away. Thanks so much.
Thank you so much for coming. What a great turnout, and a great turnout for DataCon in general. And thank you for sticking around after lunch. I'm excited to be here. I've been kind of hanging out in this particular room all day. This seems like where a lot of the data and equity and kind of social related stuff has been going on. So I'm happy to be a part of that work. So as they mentioned, my name is Ellie Albertson. I'm a data scientist at the Cedars-Sinai Health System here in LA. And today I'm going to be talking about some of the work we've been engaged in to promote use of data for health equity and reducing disparities in health outcomes for our patients. So my topic is leveraging neighborhood socioeconomic data to predict individual experiences. So a little more about me. I have about 10 years of experience doing various types of data work and advanced analytics. My background is in healthcare, but also in social services, think like affordable housing, child and family services. And like a lot of you here, I'm passionate about using data to improve people's lives. And I've done data work in various places across the country, most recently in my hometown of Seattle, Washington, and then, of course, here in Los Angeles. And since I moved to Los Angeles about 5 years ago, I've lived in a couple different neighborhoods. One of the neighborhoods that I lived in is pictured on the right. There's a lot of concrete. You can see there's a WIC clinic in the background, which provides nutrition and healthcare services for low-income families. The median household income is about $50,000 a year. About half of people don't have a bachelor's degree or higher, and about 1 in 10 people lack health insurance. Then by contrast, another neighborhood that I've lived in is pictured on, did I say right before? I meant left. Woo, that PhD is going real far. So on the right is another neighborhood that I've lived in, and you can see there's a lot more green. If you look really closely, you can see there's a playground in the background. The median household income is well into the 6 figures. There's about 75% of the population with a bachelor's degree or higher, and only about 1 in 30 people lack health insurance. So the point of making this comparison is not just to point out that we have diversity in Los Angeles, but also to point out that I didn't change when I moved between these neighborhoods. My socioeconomic status stayed about the same. My ability to meet my basic needs stayed about the same. So this raises the question of how much can we infer about an individual person based on the neighborhood that they live in? And that's a question that's becoming more and more relevant in healthcare, as well as other industries. So as I mentioned, I work for Cedars-Sinai Health System. Our flagship hospital is in the Beverly Hills, West Hollywood area. We also have a hospital in Marina del Rey, and up in Pasadena, we just acquired Huntington Hospital. And I work for the data science team, which is under Enterprise Information Services Department. Our job is pretty much operational analytics. So we run a lot of traditional machine learning models to do predictions. We are making more and more forays into generative AI, and we do traditional statistical analysis as well. And part of Cedars-Sinai organizational mission and values are diversity, equity, healthcare affordability, and healthcare accessibility. In addition, there are evolving reporting requirements from state and federal agencies that are asking us to do more and more reporting on bias and fairness and equity in healthcare. So as a result, we've increased our focus on patient social and economic data. So that's what I want to talk a little bit about today, is some of the data that we've started incorporating into our ecosystem and into our data science projects. A particular project that we've done to predict individual experiences from neighborhood data, and then some key takeaways and lessons learned that we've had from that work. So the first thing I want to talk about is what I like to call neighborhood deprivation and vulnerability indices, and I'll break that down in the next few slides. So neighborhood data, it's prolific, it's relevant in many fields. In marketing, we can use neighborhood data to provide localized messaging to current and prospective customers. In real estate, we can research the market and property values. We can identify neighborhood amenities. In education, neighborhood data is relevant for understanding potential challenges and opportunities for students. And then, of course, in health, we look at neighborhood data to identify drivers of healthcare utilization and health outcomes. But what is a neighborhood? How do we operationalize this from a technical perspective? A lot of the time we use zip code because that's what's readily available in the address files that we have. Cedars-Sinai zip code is pictured here in gray. It's a little tough to see on the screen, but if you look closely, you can see the zip code is pretty big. If we want to get higher resolution, we can look at the census tract. Cedars-Sinai census tract is shown here as a mix of the light and the dark blue. And then if we're able to get even smaller, we can look at census block groups, which are nested within census tracts. And that's shown in the dark blue on the left. And depending on the community that we're working in, we might have access to or be able to construct our own spatial files for neighborhoods, subjectively defined, for service planning areas like the LA County spas, various political jurisdictions, and hospital catchment areas, or other geographies that might constitute neighborhoods. And once we've defined our neighborhoods, we usually want to describe them somehow. And the good news is that there is a ton of data available for describing neighborhoods. One of the most common sources of information is the American Community Survey published by the US Census Bureau. Show of hands, has anyone used the American Community Survey data before in a project? Yeah, quite a few people. There's also a large number of open data portals published by our state and local governments, and universities like USC and UCLA publish neighborhood data sources that we can use to describe various attributes of the places where we and our customers live. But what if we want to summarize neighborhoods, maybe for the purpose of making a basic comparison on some metric across different neighborhoods? This is where index scores become really useful. So we actually just had a great talk in this room right before this on an index that's been constructed. In terms of neighborhood data, we can take different sources of information, weight them, combine them, and get a summary index score that tells us something about that location. So that's what I want to talk about in the next few slides, is a few different publicly available, free to access neighborhood index scores that we've incorporated into our work at Cedars-Sinai, and that maybe some of you have used or might be interested in using for some of your projects. So one of those is the Area Deprivation Index, the ADI. It's constructed from socioeconomic factors such as economics, education, housing quality, and something that's unique about the ADI is it goes down to very small geographies. Think census block groups, which in California have an average around 1,500 people each. So this data is made publicly available by the University of Wisconsin. And we can see on the map that in Southeast LA and in the northern part of the county, there's hotspots where deprivation is higher based on this index. Another index that exists in California is the California Healthy Places Index, which was constructed to describe not only the socioeconomic aspects of neighborhoods, but also the public health aspects of neighborhoods. So there's factors for things like healthcare access, clean environment. And the California Healthy Places Index makes a wide swath of data available for analysis. There's over 23 individual data items that are publicly available, plus domains and an overall score. However, it's available only for California. The Social Deprivation Index is yet another, similar to the Area Deprivation Index in that it's constructed from 7 economically focused factors. It's available for a variety of geographies, which is helpful. So zip codes, census tracts, even primary care service areas. And again, we can look at the map and see similar hotspots as we saw with the Area Deprivation Index. Only 2 more of these. The Social Vulnerability Index is a 4th index that has been widely used because it's published by the federal government. It has a socioeconomic focus, but with a focus on the social, I would say. This is the only one of the 5 indices that we use that includes race and ethnicity as a factor, as well as other social attributes of neighborhoods. And then newly published this year is the Vizient Vulnerability Index. Vizient is a player in the healthcare data space, and they've made publicly available their own index that measures neighborhoods, socioeconomic, and public health factors. Similar to the Healthy Places Index, this includes things like clean environment, healthcare access, also public safety is in here. They publish, I believe, 9 domain indicators and an overall score. And an interesting thing about the VVI is that the item weights are tailored to each region of the country. So the idea is that that you can see what's relevant in your region. And you can see on this map that the VVI gives a little more homogeneous of a view of Los Angeles compared to the other indices. So a question that we started asking in the healthcare space, and I think in other arenas as well, is how much do neighborhood data reflect the individuals that live there? So you can imagine if you have a census block group like this one that has an area deprivation index of 6 out of 10, there's some distribution of people in that neighborhood with various life experiences, various experiences of what we might call deprivation. So how do we get at that using neighborhood data, and how much can we really tell? So that brings us to the project that I want to talk about today that we've been working on at Cedars-Sinai to predict individual experiences from neighborhood data. So in healthcare, something that I think we talked a lot about during the pandemic, especially, and hopefully have continued to talk about, is the importance of social and economic factors in influencing health. These are some headlines from recent articles from the past month or 2. Being socially frail comes with health risks for older adults. COVID-19 had a devastating and disproportionate impact on the poorest Americans, and so on. So we're seeing social and economic factors become intertwined in how our healthcare system operates and how we do data work in the healthcare system. And it's difficult to estimate exactly how much social and economic factors contribute to healthcare outcomes and utilization. Some studies have estimated that about 40 to 50% of health outcomes are driven by our socioeconomic status. Some studies have estimated that it's even more. So as a result, health systems, partly driven by changes in national policy and in regulatory requirements, health systems have started collecting social risk screenings from some or all patients, depending on the context. So when I say social risk screenings, what I mean are structured questionnaires that are being asked to patients in the health system when they come in for care, or sometimes before they come in for care. And these questionnaires ask questions about topics like food insecurity. Within the past 12 months, were you worried that your food would run out before you got the money to buy more? Housing insecurity, what is your housing situation today? Are you worried about losing your housing? Financial resource strain, how hard is it for you to pay for the very basics like food, housing, medical care, and heating? So we're starting to collect these surveys at Cedars-Sinai for all inpatients and then also for some outpatient settings, outpatient meaning care that's not an overnight stay in the hospital. And a typical workflow for collecting these screenings looks something like this. A patient will come in, they'll get registered at the hospital where we provide our name, our demographics, maybe our address. We're assigned to a provider, typically a doctor, a nurse, maybe a social worker, depending on the setting. And then that provider would screen the patient for social risk. And this is often done by providers because social risk screenings can be sensitive information. It can be something where the hospital wants to use it to refer people to services. So they want to make sure a provider is involved in some cases, rather than just having patients fill out the screening on their own or at registration. So the question that we're starting to ask at Cedars-Sinai is there a way that we can start predicting someone's level of social risk before they go through this process of talking to a provider and maybe being screened, maybe not even being screened if it's not possible to do given the context. So we're interested in using machine learning methods to predict a person's social risk based on the data that we have available before provider assignment or even before registration. There we go. So what we've done at Cedars-Sinai is we've leveraged our social risk screening data in machine learning models to see how much we can predict about someone's self-reported social risk based on other information that we have about them, including their neighborhood of residence. So we took about 14,000 patients who were screened for social risk in 2022. Again, for those three domains that I mentioned, food insecurity, housing insecurity, and financial resource strain. We geocoded the patient addresses to their census block group, meaning that we located which census block group they lived in based on latitude and longitude. And then we compiled neighborhood data for those patients from the 5 indices that I mentioned earlier. And as I said, we treated this as a machine learning problem, as a predictive model. So we used a binary classification approach where a patient was defined as having social risk, self-reported social risk, if they screened positive for one or more of food insecurity, housing insecurity, or financial resource strain, and they were defined as having no social risk if they screened negative for all 3. And that was based on a similar study in prior literature. So when we started looking at the numbers, we found that in our sample, about 17% of patients reported social risk, while the remaining 83% or so reported no social risk based on our definition. So there was some class imbalance in the sample, and we addressed that in our analysis. And just as a reminder, this is not a random sample. So this is not necessarily representative of the community or even of our patients as a whole, but it's a convenient sample based on what we had. So now it's time to get into some maps. I'm sure there's some GIS nerds in the audience like myself who love maps. We're going to see a lot about LA's geography today. So on the left is a map of who was screened, through our screening program in 2022. And we can see that the dark spots are primarily in west central LA, which is Cedars-Sinai primary service area. So that makes sense. On the, you're right, is a second map that shows where people reported that they were experiencing social risk. So this is where we started to see geographic clustering in southern Los Angeles and in central Los Angeles of people self-reporting social risk, although there was still some distribution across the city. We looked at the demographics of who reported social risk versus not. We did see some disparities. For example, 35% of people who reported social risk identified as Hispanic or Latino, compared to 20% of those without social risk. 20% identified as Black or African American among those with social risk. We had slightly higher percent male and under age 65 in the social risk group. And then also 27% of those with social risk were on Medi-Cal, which is California's Medicaid health insurance. So this diagram shows our modeling approach. We constructed our population data set. And when we did that, we constructed our social risk binary label. We also took the neighborhood indices that I showed you before and scaled them between 0 and 1, with 1 indicating the most disadvantage. The raw scales are not equivalent for those indices. We created a training set and a holdout set that the model would never see during training. We used a stratified split to keep the proportion with the label similar in both the training and the holdout due to the class imbalance. And then we took subsets of the columns in our data set to construct 6 feature lists. And when I say features, I mean predictive features or the columns or variables that we're feeding into our models as predictors. So we constructed 6 feature lists to feed into 6 different models, 1 list for each of the 5 indices that I mentioned earlier, and 1 for all items combined from those neighborhood indices. We ran some preliminary models in Python to just see what the results might look like. And then we used an automated machine learning platform to run our final models, and that facilitated comparison of a large number of models and also automated hyperparameter tuning, which made my job easier. And we used stratified tenfold cross-validation to try to make the results robust. So finally, after going through that process, we made predictions on the holdout set and on subsets of the holdout set, because we also wanted to understand how the model was performing for potentially vulnerable subpopulations. So the number of features in each model varied. As I mentioned, we had 6 feature sets, each of which fed into its own model. For example, the area deprivation index only makes 2 columns or 2 features available for analysis publicly: a national ranking and a state ranking. And those rankings are correlated, so it's really kind of like 1.5 features. The Healthy Places Index, by contrast, provides data for all of the individual items that compose the index, so you can get a lot more richness out of it. And our all items model had 57 features combining the others. We found that an XGBoost model performed the best for the ADI, and the light GBM model performed the best for the other feature lists. So some ensemble models going on. And I wanted to, before I dive into results, I wanted to give sort of a review of some key model performance metrics for those of us who don't work with them regularly. So when we're talking about sort of basic binary classifier machine learning problem, we can look at area under the curve, the AUC. We can look at precision, and we can look at recall. These are 3 of many model metrics, but there are 3 that I selected for presenting today. And for each of these, a value of 1 is what we're aiming for. Things below 1 are not so good. For AUC, a value of 0.5 means that the model's predicting about the same as a coin flip, about the same as random chance. So finally, we did all this work, we ran our models, and we got these results. So the good news is that our models were predicting better than chance. Our neighborhood data was letting us tell something about individuals. But the bad news is that our AUCs never really broke past 0.7, whereas we would prefer to be seeing them quite a bit closer to 1. Our precision was pretty low, and our recall was low to moderate for each of the models. And the different feature lists representing the different neighborhood indices all performed remarkably similarly on some of these metrics, I think, given that they were constructed in totally different ways. So when we talk about predictive models, we can take a look at feature importance rankings. It's not always the best thing to do, because especially when there's correlation or collinearity between features, the features that kind of float to the top as being most important for predictions aren't always the most reliable to look at. But I think it's nice to take a look under the hood and see which features are floating to the top as being important and influential on predictions. Something interesting here is that education showed up a few times. It's highlighted here in very light blue. That's difficult to see on the screen. Transportation showed up a few times as an important feature. Interestingly, clean environment variables and pollution variables or features showed up. And we actually had a talk in this room earlier this morning about air pollution in Los Angeles and some social equity stuff there. What's also interesting is what did not show up much as an impactful feature on predictions, which is housing. Housing only showed up as impactful for one model, really. And that's possibly because everyone is struggling with housing in LA, so it's not necessarily as much of a differentiating factor as other neighborhood attributes. We also took a look at our model performance metrics for subpopulations based on race, ethnicity, gender, age, language, and also health insurance payer or health insurer. So as some examples, we found that AUCs were even lower or closer to chance for patients in the sample who identified as Black or African American, who identified as Asian and speaking a language other than English, who identified as white and speaking a language other than English, who were 85 and over, on Medicaid, and dual eligible for both Medicaid and Medicare insurance. So what this is showing is that when we look at subsets of the holdout set, the model is not predicting well, it's not distinguishing well between patients who did and did not have social risk when we look at certain subpopulations that we might be wanting to pay attention to. Results by geography were interesting. AUC, we didn't see too much of a pattern, but we did see some geographic patterns with the precision and recall when we looked by zip code. So in these maps, darker color indicates poorer model performance, so a value closer to 0. So the precision was quite bad, even worse than for the overall model in for patients when we stratified to patients who were in Southeast LA. By contrast, recall was not great for patients in West and North LA. And when we looked at results by neighborhood vulnerability, we also saw some differences. So as an example, we stratified results by whether a patient was in a high social vulnerability index neighborhood. And we found that patients who were in the highest vulnerability neighborhoods, if we stratified to just them in the holdout set, the recall actually starts to look pretty good. So the model's starting to kind of generously predict that people will be that people will have social risk when they come from high vulnerability neighborhoods. So that's a lot of numbers. Thanks for bearing with that, especially people who don't do number stuff. I want to now step into the third section of my talk, which is about key takeaways and lessons learned from all of this. What does all of this actually mean in terms of how we move forward with data analysis? So even though our models found that neighborhood data was not fantastically predictive of individual level social risk, neighborhood data still has value. There's a reason why you all are at this talk. There's a reason why this data is so prolific and publicly available. You know, neighborhood data is really good for measuring neighborhood level stuff like pollution or the social environment. Neighborhood data is also really good when we're planning something and we want to reach an average consumer, or we want to reach a certain community with certain average attributes. Like in healthcare, we might be citing a new neighborhood clinic, or maybe you're looking to cite a new retail store. And then, as I mentioned, we were making better than chance predictions. So if nothing else is available and we're trying to guess what someone's individual experience might be, neighborhood data can shed some light on an individual's socioeconomic status to a limited extent. But there were limitations. So as I've highlighted, there's potential error in assuming individual level socioeconomic experiences from neighborhood data. And that might seem straightforward or like something that we would know without going through and running all the numbers. But it's important because in healthcare especially, we're using neighborhood data more and more as a proxy for someone's individual socioeconomic status. Analyses like this show the real impact of that ecological fallacy where we're making assumptions based on area estimates. We also saw greater error for some populations. And then another point that I haven't highlighted yet is there's typically a time lag between neighborhood data and the current data that we're using. So often we have current addresses or recent addresses, but neighborhood data like the American Community Survey typically lags a few years behind. And interestingly, the findings of our analysis are reflected in research that's been published across the country. So this study is from 2020, and they compared the social deprivation index to individual social risk screenings in a health system, just like we did. And what they found was patient and community level approaches for assessing patient social risks are not equivalent. Another study from last year, I believe 2022, had similar conclusions. We found only modestly greater social risk reported by patients in the least resourced neighborhoods. So they found limited correlation between neighborhood socioeconomic status and individual socioeconomic status. And then a third study, just to reinforce that our analysis is not alone. Again, comparing the social deprivation index as well as the area deprivation index to patient social risk screenings. Their analysis found that area level deprivation indices may be inconsistent indicators of individual level social risks. And their conclusion was that this supports policy efforts to promote individual level social screening programs in healthcare settings, which is the direction that the industry is going. So to sort of wrap up here before we do Q&A, I wanted to share this map, and it's published by CNN. It's a pretty cool map to play around with if you Google like CNN race and ethnic diversity maps. And as I just mentioned, what this shows is racial and ethnic groups across Los Angeles, where each dot represents, I think, 150 people, and each color represents a different racial or ethnic group. So what we can see is some segregation, but also a lot of diversity. You know, that diversity is a big part of Los Angeles, but it's also what makes it hard to make conclusions about individuals based on the neighborhoods that they live in. So our conclusion from going through this process was that wherever possible, it's best to try to calibrate and supplement neighborhood data by using individual level data when we have access to it. So with that, I'll say thank you, and I'm curious to hear your thoughts and comments. Thank you.
Does anyone have any questions?
Thank you for sharing. I want to say your analysis definitely not alone because right here, I'm Eva. I want to say like I've done a very similar project before, like trying to use the demographic data to predict people's mental health score. So, but our model's result is not that good too. So I will say that like your analysis definitely not alone. And I have a question regarding the features, like besides the indexes you used, are there any other features you're using, or like how large the features are?
Yeah, that's a fantastic question. And one thing that I didn't have time to get to before this slide deck was we're working on adding in individual level data as well. So if we're thinking about predictions happening right after somebody's registered at the hospital, we would also have, in addition to address, things like patient demographics that could be helpful in predictions or could perpetuate bias if we use them the wrong way. So we're thinking about, you know, other potential indicators of someone's socioeconomic experiences and whether that can improve model performance based on when we have limited information about them. And it's interesting that your project was about predicting mental health scores, because a lot of the indices, or at least two of the indices that I talked about, the Vizient Vulnerability Index and the California Healthy Places Index, were developed with a goal of correlating with health factors such as life expectancy. So there's kind of an intention for some of these indices to be predictive of health status, but not necessarily to be predictive of what somebody's socioeconomic experience might be.
Any other questions?
Do you see these individual characteristics, neighborhood characteristics, being used to sort of correlate with like stress-related biomarkers to predict like disease and medical outcomes? Is that like ultimately the end goal, is to use this information to predict out services or potential outcomes from a health standpoint?
Yeah, great question.
Because getting zip code and the patient's demographics is pretty easy. You can access that pretty easily. Taking blood and saliva and running a bunch of assays and coming up with some sort of index of stress-related biomarkers is a lot more time-consuming, invasive, and costly. Is that ultimately, though, where this is headed, though, to be a proxy for that?
Yeah, that's a fantastic question. And I'll repeat it just for the video recording. The question is whether, let me know if I'm wrong, but the question is whether we're using neighborhood data plus demographics and readily available information to predict things like biomarkers or physical attributes of patients or other health status, health outcomes kinds of stuff. The answer is yes. We have a really fantastic omics team, genomics, and all the other omics. And they're definitely equity minded, and they're considering opportunities to be bringing other types of data into their work, from what I understand, at least. So the answer is yes. And I think predicting health status based on neighborhood attributes is something that might be a little more successful than trying to predict patients' individual level attributes or their individual social risk screening scores.
I want to ask you if you have faced the need to discriminate between models given the need for audit or for like explainability in the model given the outcome that you're trying to get at.
Yeah, sorry, can you repeat that one more time? Sorry.
Yeah. I was curious to know, like, if when you were discriminating between models, you face a need to say like this model is too complicated in terms of being audited. Like you are using like information from like a zip code, kind of like sensible information, and it's probably gonna be faced like subject to like regulatory or things that could be needed to go through an audit process. And you are trying to avoid like black box models that can be like auto-explainable in the research.
Yeah, really great question. And actually the California Attorney General's office has kind of put out a decree that healthcare organizations will be examined a little more closely for how we use artificial intelligence and machine learning. So it is important, to have that auditability or explainability in the models that we run. That's not to say we do use generative AI, we do use neural networks, we use all kinds of models, but being able to kind of explain why we got the results that we got is a really helpful thing, especially in healthcare.
Do you want to do a follow-up?
Yeah, well, do you actually like discriminate between models for that purpose, or?
Good question. In this case, the model performance wasn't really good enough to give us much of a choice. But it would depend on the project. Like as an example, sometimes something as simple as a decision tree is better to use just because it does have like it's on the more extreme end of being more explainable than another type of model. So it's something that can factor into the model choice. In this case, we just kind of went with whatever optimized F1 score, and like that was it. But really good, really good question.
I was just curious, how are you feeding this information back into like healthcare workers to improve outcomes?
Yeah, another fantastic question. So right now we haven't put the predictive models into production because they're still under development. But in an ideal world, we can, in other predictive models that we've put together, we can feed information back to healthcare workers either through the electronic health record directly. So we're on Epic, which is what many health systems are on, and there are ways to build in things like best practice alerts or other kinds of notifications related to the results of predictive models that we run in-house. That's not an easy task to integrate into Epic, but it's definitely possible. Another thing that we've done, honestly, is just building pipelines that leverage Tableau and making, lists of high-risk patients available at a certain cadence to the right providers, depending on the context. That can sometimes work. But Epic is kind of the preferred thing. Providers shouldn't have to look at a bunch of different things to get information.
And how do you quantify the positive outcomes? Like, can you quantify how good your work is making this better?
Yeah, the tough thing about this kind of predictive work in healthcare is we want it to change outcomes, right? So kind of what's our counterfactual? Like, how do we set a baseline? So with COVID, that's a little difficult, but what we can do is look in the past and say, okay, our rate of XYZ was this, and I'm speaking very generally about clinical predictive models, but our rate of an adverse clinical outcome was this. We implemented the model, the rate has gone down. It's more difficult directly attributing that to the model itself, but yeah, so we kind of have to work with the observational data that we have. We can try to do it more experimentally, but in reality, it's healthcare, so we just want to do the best we can for every patient.
This is probably going to sound like a bad question, but in looking at the way people live, some people shop at a dollar store, they shop at a Walmart, a Target. Is it possible to look at that data as well and figure out how far the average person lives from there, or the density of dollar stores in an area versus Walmarts or just liquor stores or things like that? Because that would feed into how they live and maybe inform something else.
Yeah, no, actually that question hits on another type of data that we have in our sort of toolkit at Cedars, which is we do have market research data that relates to like consumer spending, and it sheds light on things like that. Also, things like density of certain types of retail are built into some of the neighborhood indices that I talked about. So there's definitely some potential there for that to be predictive of an individual's social risk. But yeah, it's kind of like the same problem with all this neighborhood data, which is we know that there's some distribution, we know that there's some variation and diversity within each neighborhood. So it's hard to know exactly what one person's experience is, especially when there's the additional selection of they're not only in that neighborhood, but they're also a patient at our healthcare system, or they're also a customer of our business. So there's some selection in that. So we're still trying to figure out the best way to kind of calibrate these neighborhood data to be more informative.
So is that to say that, part of the focus for your team is to try to get, you mentioned the sort of predictive power. I think some of them were in the 6s, and I think you said they didn't breach like 0.7 or so. Is the approach trying to get closer to 1 with the neighborhood data? So in some sense, trying to go further with your predictive power with the neighborhood data, or are you trying to get better prediction closer to 1 by next adding individual data?
Yeah, I think maybe a little of both. So I think we might be able to squeak out some more predictive power by adding like more on demographics, but with the caveat that like demographics might be problematic when trying to predict. Like, for example, like we already are seeing some potential like biases in the model, and we want to make sure we're not perpetuating that by just dumping a bunch more demographic information without reviewing it. And the interesting thing that the Census Bureau publishes at the state level, and that you can calculate yourself, but we haven't yet, is neighborhood diversity indexes. So you can kind of calculate how diverse a neighborhood is by comparing the distribution or the proportions of people in different demographic groups. So it's possible to construct an index like that. My theory is that if we started incorporating neighborhood diversity indices, we might see some interesting results, because I think more diverse neighborhoods will have less consistent predictions about who's in social risk or not, whereas more homogeneous neighborhoods will be able to get a better read on what someone's experience might be. So that's the potential next step that we're thinking about including.
Any other questions?
More of a modeling question. So you mentioned that you used an AutoML system for your actual modeling, but you guys are, I guess, there's some pretty strict rules about how you can share case data and how you can train models. Does that mean that you're just very selective in the platforms you chose? And then also, I'm curious what the platform was that you did choose for your modeling.
Yeah. Let's talk afterward about the platform. And so, yeah, feel free to come up and chat about that part. But yeah, in terms of how we choose models, yeah, usually we just kind of go on for this project, it was on model performance much more than like explainability. I'm not sure if that answers your question.
More so like the data you use. So like using potentially private patient data, which if you're putting on like a off-premises.
Yeah. That's a fantastic question. So yeah, the question was, how do we handle like data privacy and security? Anyone who's worked in healthcare knows that that's a very big deal, super relevant question. We have an on-prem server version of the AutoML software that we use. So there's no data going off premises at all. We also do our geocoding securely and internally. So we have an automated job that we set up to run that geocodes patient addresses on a daily basis. And that's all done using a database that's been downloaded and is all internal. So we're very cautious, extremely cautious, and make sure that none of this highly sensitive information gets out there. But that being said, I am really glad I don't work in healthcare data security right now.
I had a question about the impacts that this type of research could have on accessibility. Notably, like I know that like in such a case, if you're looking at socioeconomic status and the providers, for example, they have access to that, whether that will bias how they treat their their patients, or what type of care they will receive ultimately.
Yeah, and that's something, I know there's been at least one project in Cedars-Sinai that has looked at bias in sort of like the language that providers use when documenting about patients. It's definitely something we're paying attention to because especially with these individual level social determinants of health screenings, there could potentially be stigma. We want to be providing resources that support patients where they need it. We're also more and more mandated and interested in collecting this information. But the flip side is that it is highly sensitive information. And then you asked a little bit about accessibility. So just making sure that patients still have access to high quality care regardless of their socioeconomic status. Is that sort of?
Yeah, I mean, like with that, I guess like along with the bias that could potentially exist, whether that could impact the accessibility to care that patients receive.
Yeah, definitely. And I think like that's something that we all have to watch out for in health and human services more broadly, is kind of the differential information and differential power dynamics between providers and patients or clients. So yeah, it's definitely possible that knowing a patient's socioeconomic status could influence the care they receive. In some ways that already has the potential to happen, because when patients come in on Medicaid health insurance, that's an income limited program. And it also directly affects what providers are able to see the patient on insurance. So there's definitely a lot of complexity. As I mentioned, Cedars-Sinai, one of our values really is healthcare accessibility and healthcare affordability. We have an Office of Health Equity that kind of keeps an eye on this stuff to the extent possible, and we're working on documenting it. So really good question.
think that's all the time we have for Q&A. So if we can give a round of applause to Dr. Albertson.